So acute cholecystitis and gallstones are probably like the bread and butter of doing abdomen ultrasounds. Any sort of pain in that right upper quadrant, doctors want to know, A, are there gallstones possibly causing that pain? And B, if there are they impacted and causing acute cholecystitis? So you can have gallstones without cholecystitis, but once that cholecystitis has set in, the patient has moved into more of an emergency patient and they are going to need surgery sooner than later. So the definition of acute cholecystitis then is the inflammation of the gallbladder caused by persistent obstruction of the neck or cystic duct by an impacted stone. So we know that if we're scanning a patient that has gallstones, we're rolling them around, seeing if those stones can move. Now with acute cholecystitis, gallstones are going to be present. And when we roll that patient, we're going to see that a stone is stuck in the neck. So that is something that we want to prove to the radiologist. And with that stone stuck in the neck, the gallbladder can no longer function the way it's supposed to. And so all that bile kind of gets stuck in there, simmers in there, starts to produce some bacteria, infections set in, and then now we've got acute cholecystitis on our hands. Clinically, these patients are going to have a lot of right upper quadrant tenderness. They're going to have pain in the midline or epigastric area, and that pain is actually going to wrap around to their right shoulder. So they're going to have a lot of the same symptoms that they're going to have with gallstones. The other thing that we're going to see then though with acute cholecystitis is because this is an infection of the gallbladder, we're going to see some classic infectious symptoms. So we're going to see an increase in white blood cell count. We're going to see a fever, fatigue, all that stuff that goes along with being ill. Another assessment that the clinician can do is looking for a Murphy sign. And a Murphy sign is actually something you are going to look for as a sonographer as well. So when the doctor is feeling around on the patient's abdomen, they're going to be looking for a positive Murphy sign. So if the clinician puts their fingers right underneath the costal ridge, right above where the gallbladder is felt, they're going to have the patient take a big, deep breath in while they're kind of palpating that gallbladder. As the patient breathes in, if they have cholecystitis, that gallbladder is going to come in contact with the pressure of their fingers, and it's going to cause a lot of pain. And so they're all of a sudden going to kind of stop breathing, and that's a positive Murphy sign. So you're actually going to be able to do the same thing with your transducer. When you have the gallbladder imaged on the screen, you're going to be subcostal to where that location is. You're going to have them take a deep breath, watch that gallbladder slide underneath the pressure of your transducer. If they kind of take a sharp breath in or stop breathing in, that is going to be indicated, or that indicates a positive Murphy sign. So you're going to want to make sure that you are indicating that on your worksheet. Now, some downfalls to diagnosing that positive Murphy sign is that a lot of times those patients are going to be coming into the ER and they're in so much pain, and quite often they're going to get something called a GI cocktail. And in that GI cocktail is some pain medicine. And so their positive Murphy sign might be a little dulled because of that pain medicine. The other thing is that we are right on the ribs when we're doing this. And if you're adding enough pressure, some people just have very sensitive costal ridges, and just being on the ribs can be kind of painful. So you want to make sure that if you're calling it a positive Murphy sign, that it is from pressure on the gallbladder as it slides underneath that transducer. That is what's going to elicit that true positive Murphy sign. As I mentioned at the top of this, the treatment for acute cholecystitis is a cholecystectomy. That is the medical term for gallbladder removal. A lot of people will have gallstones and not necessarily go straight to a cholecystectomy until it's causing enough pain or has turned into a case of acute cholecystitis. Because acute cholecystitis is not only basically a surgical emergency, but it's also super common finding on ultrasound, especially from emergency room patients. And so we want to make sure that we are able to diagnose acute cholecystitis with our pictures and get all the right information to the radiologist so they can make that call. Acute cholecystitis has very specific things that we are going to be seeing. So one of the first signs of acute cholecystitis is going to be a thickened gallbladder wall. Recall that a gallbladder wall should not measure over 3 millimeters. Anything more than 3 millimeters is considered thickened, and in the presence of pain and fever, that is a big indicator of acute cholecystitis. The other thing that we'll see with acute cholecystitis is a distended lumen. If you recall, that gallbladder is kind of blocking everything, not allowing that bile to back or get out of the gallbladder, and so you're going to have a large distended gallbladder. It can measure over 10 centimeters in long or more than 4 centimeters in transverse. Another sign of acute cholecystitis is the presence of pericholecystic fluid. Peri means by, cholecystic is the gallbladder, so it's fluid by the gallbladder. So outside of the gallbladder wall, you will typically see a thin anechoic line that typically represents pericholecystic fluid. Quite often, I feel like we see it a little bit more in between the liver and the gallbladder. Sometimes you will see it on the other side towards the fundus as it kind of drapes into the intestines. So make sure you're looking at where that fluid sits, both supine and decubed. Gallstones are also a very common aspect to the acute cholecystitis. It's actually the reason why the acute cholecystitis exists. So you're going to typically find a gallstone up in the neck that is non-mobile as you roll that patient around. These pictures here show more examples of acute cholecystitis and really show the gallbladder wall to be very thickened. And what you'll see through this gallbladder wall is that it has striations. And striations are kind of a last level acute cholecystitis. This gallbladder has to come out pretty much immediately. So it does kind of start out as a thicker, echogenic, 3 millimeter plus wall. They can get up to 7 millimeters, 9 millimeters, and then start to have kind of these cystic spaces in between them. Those are going to be more concerning for more advanced, more difficult cases of acute cholecystitis. Lastly, you will want to try to put on color Doppler. This picture shows us with power Doppler, and that power Doppler is going to show us an increased vascularity around the gallbladder. And this is typical for anything that is inflamed. There's typically more blood flow going to the area, so any sort of inflammation typically causes an increase in vascularity. So again, acute cholecystitis is such a common finding on ultrasound, and ultrasound is actually the gold standard to diagnose acute cholecystitis. So we're looking for a thickened gallbladder wall measuring more than 3 millimeters in diameter. We're looking for a positive sonographic Murphy sign. We are most likely going to see a gallstone impacted in the neck or cystic duct of the gallbladder. We will also possibly see some pericholecystic fluid and increased vascularity of the wall.